Um, in this particular presentation, I'll be giving you a very broad introduction to thyroid disorders from the endocrine perspective. I do not have any particular disclosures. And at the end of this talk, I would hope that you will have a better understanding of the basics of thyroid hormone regulation, thyroid blood tests. We will go through differential diagnosis of hyper and hypothyroidism and very broad principles of management. Thyroid gland, as I'm sure the audience know very well, is a bilobar gland. There are two lobes, the right and the left lobe, which are joined together by the isthmus. So the right lobe, the left lobe, and the isthmus. And it wraps around the thyroid cartilage. This is a picture I took out of a book that I wrote last year in neuroendocrinology. Thyroid is controlled through hypothalamic pituitary system. Thyroid is a very important gland from the endocrine perspective, and it works in conjunction with your hypothalamus and your pituitary and controls and regulates your metabolism. Now, as obviously the seasons change, and you can probably still see lots of snow outside, the daylight hours change, and all the other things that change around us, that has a profound impact on how our hormones are regulated. All these day and night cycles, the temperature cycles, they actually are assessed by our hypothalamic pituitary system. And then in turn, the hypothalamic pituitary system then controls your hormones. And that is why in many cases, many of our hormones, there is a very specific pattern to their release. For instance, your cortisol hormone, your reproductive hormones, and even thyroid hormones, you will see that the levels will change over the course of the day. Some of these changes are very profound, and they can happen over the course of a day, and this is the diurnal rhythm. And sometimes these changes, they happen really on a minute-to-minute basis, and you get peaks and troughs. So in essence, as this slide is showing, your hypothalamus produces a hormone called thyrotropin-releasing hormone, TRH, which basically acts on your pituitary to release TSH. And as you can see, that TSH acts on your thyroid gland, and it leads to release of T4 and T3, primarily T4, a little bit of T3. And T4 and T3 in turn then feedback is like a regulator on the wall, and it feedbacks into your hypothalamic pituitary system. And this is a self-correcting, self-regulating. If you look at the daily thyroid hormone production, your thyroid primarily produces T4. That is the key hormone. And you produce approximately 100 micrograms of thyroxine a day. Very small amount of T3 is produced, which is only 6 micrograms a day. So if you were to look at the T4 to T3 ratio in a day, it's approximately 14:1. Now, T4 is more protein bound. It's a much more stable hormone. And if you see that only 0.03% of T4 is available as free thyroid hormone. Rest is bound to protein. Now, T4, the total amount of T3 that you need, only 15% of that T3 is produced directly by thyroid. The rest of it is converted from T4 into T3 as and when needed. And 0.3% of T3 is available as free hormone. Now, you may not see a big difference between 0.03 and 0.3, but this is actually 10 to 20 times more T3 is available as free hormone to bind to its site. If we were to compare T4 and T3, so T3 is about 10 times more potent than T4. The binding of T3 is less, 10 times less as compared to T4. And because of the fact that this is more readily available, it has a shorter half-life. And T3 is generally destroyed within a few hours of being released. And the half-life is less than 24 hours, which is why if we need to give replacement with T3, we have to do it several times a day. On the other hand, half-life of T4 is almost a week, and this is why in some patients, when we give them replacement with T4, we can give it 2 to 3 times a week. And it is perfectly reasonable because it is a much more stable hormone. And as I said earlier, approximately 100 micrograms of T4 is released a day as opposed to about 6 micrograms of T3. So the ratio is approximately 14:1. How do we deal with thyroid problems? So as a first step, when we want to look at someone's thyroid status, we measure their thyroid hormones. The key hormone is the TSH, and we all know that. And if I were to ask someone to do one test only in the general population, then TSH alone would be that particular hormone. It is important to keep a very close watch on the reference ranges because TSH reference ranges vary from one lab to another. And also TSH reference ranges should ideally be different in children versus older individuals, because as we get older, our TSH values tend to rise a little bit. And if we are using the same reference range in the elderly as we do in younger individual, we'll probably be over treating our elderly population. And that is unfortunate because we really need to have age-specific or somewhat age-specific ranges. Another important aspect to remember is that there is a significant difference in these TSH reference ranges in pregnancy. So pregnancy should ideally have its own specific TSH ranges because TSH can vary quite a lot during pregnancy. As women get pregnant, their TSH levels drop into lower end of the normal range or actually even below the normal range. So it is very important to be mindful of these changes. So TSH will tell you the brain's or pituitary's interpretation of thyroid hormone levels. The second test is T4. In our lab, the reference range is between 9 to 19 picomole per liter, but these, I'm sure, depending upon what units you're using in whatever country you're practicing, these numbers can be different. And as said earlier, 80% of the thyroid hormone is synthesized as T4, and then that gets converted, part of that gets converted to T3. T3 in our lab is measured in picomole and is 3.5 to 5.9, and active hormone It is the active form of the hormone. And always when you measure, it is important to measure free T4 and free T3 as opposed to total T4 and total T3. And the reason I'm saying that is because your total T4 and total T3 is very much dependent upon the protein binding. Because if you, as I was mentioning earlier, your thyroid hormones are primarily bound to protein. If you have some medical problem, there are some drugs, there are other health issues which can lead to change or variation in your protein level. And if you measure total hormone levels, then what you will find is that as the protein levels will change, your total thyroid hormone levels will go up and down accordingly. And that can give you a false reading. Therefore, the hormone that remains essentially somewhat stable is your free hormone. And therefore, if you measure free T4 and free T3, you kind of, in most cases, circumvent. So let's talk a little bit about hypothyroidism. Hypothyroidism, in essence, is decrease in thyroid hormone levels. So you will typically find that T4 level will drop. Now, you will be amazed to find that in many cases where T4 level is below the normal range, actually T3 remains normal, because T3 is the active hormone. And even if your T4 level, which is a storage hormone, is low, your body will still try to continue to maintain the T3 level in the normal range by increasing the conversion of T4 to T3. This is why you have a much higher production of T4, so that you have a bigger pool. And even if the pool shrinks, you still need only a small amount of T4 to convert to T3, so you can maintain your metabolic milieu. And obviously, as the T4 drops, your TSH will begin to rise. And that will happen unless somebody has a pituitary tumor or a pituitary problem. In these patients, your TSH will not rise. So in that case, you will find that the T4 is low, maybe T3 is low, and TSH is either below the normal range or maximum in the normal range. It doesn't rise to above that normal range, which you would typically see in most patients. So that is an important thing to keep in mind, that in patients with pituitary disorders, your TSH may rise. The features of underactive thyroid are illustrated on this slide. You can start from the top. You have dry hair, dry skin, you have bradycardia, you have constipation, menstrual irregularities, you have skin problems, your muscles, the muscle activity slows down, and as a result, when you do the reflexes, there is a delay in relaxation phase after that, and there's a lot of mental fogging and all the rest of it. So all of these, you're well aware of the symptoms of underactive thyroid. What causes underactive thyroid? Well, worldwide, if you look at causes of underactive thyroid, the most predominant cause is actually iodine deficiency. However, in North America and many of the developed countries, where iodine deficiency really does not happen. In fact, if anything, we give too much iodine. You mostly need, as much as 50 to 100 milliequivalents of iodine a day. In our society here, for instance, some people, because milk is fortified and flour is fortified, foods are fortified, salt is fortified, you get as much as 500 milliequivalents. So that's what 10 times the daily requirement. So in our societies, in the developed societies, the commonest cause is actually autoimmune problems. Then you get inflammatory thyroiditis, which is typically due to viral infection, drugs such as amiodarone, which is and lithium, which actually leads to entrapment of thyroid hormone. And you know that from your nuclear medicine scans, that if lithium can give you falsely high values because it traps your thyroid hormones in the thyroid. Surgery, radiation therapy. I don't want you to worry about thyroid hormone resistance. It's a very, very uncommon problem. And obviously, secondary hypothyroidism due to pituitary damage, which leads to reduced stimulation of thyroid gland. So these are causes. This is a picture I took off the internet a while back. This is someone who had childhood, myxedema due to iodine deficiency, and these people they have short stature, and they have a lot of other problem, coarsening of facial features and all of that. When you are concerned about hypothyroidism, the things that you take a proper history, and you want to take medication history. Is the patient taking drugs like lithium amiodarone? Because of its very high iodine load, it actually can cause inflammation of the thyroid. And these two medications can actually lead to hypothyroidism. You have to ask patients about recent pregnancy, because pregnancy can, if particularly in Pakistan, where there's iodine deficiency, can lead to hypothyroidism, also autoimmune problem, and then pregnancy can also lead to postpartum thyroiditis in some patients, and this is again an immune response. If you take a certain amount of iodine, and you know it very well, and I'm not going to bore the audience. I mean, this is basically a condition, as you know, is called Wolff-Chaikoff phenomenon. You give a big wacky dose of iodine that essentially shuts down the thyroid. We use that for treating overactive thyroid, but if patients who take lots of iodine, contrast media, seaweed supplements, that is going to shut down your thyroid. And I'm sure, you know, from this is a nuclear medicine audience, so you probably are very well aware of this phenomenon. Radiation treatment to the thyroid or neck area for any reason, that is going to cause underactive thyroid. History that would concern you of pituitary problems, and of course family history of thyroid disease, that would point towards the possibility of autoimmune thyroid problems. Now, what are the tests that you would use to check autoimmune thyroid problem, which is the commonest problem in
Dr. Imran?
Yeah. How do we treat hypothyroidism? Well, we measure TSH, and we basically adjust the medication based on TSH in people who have normal primary hypothyroidism. If they have pituitary problem, then obviously TSH cannot be used. In that case, you base it on T4. In most cases, though, if the TSH is significantly elevated, i.e. over 10, and they have clinical symptoms of hypothyroidism and have a low T4, you treat them with thyroxine. And you treat them until TSH normalizes and keep it there. Many patients you will find they get routine TSH done, which is kind of between 5 to 10 or thereabouts. They have normal T4. They don't have very many symptoms. In general, we don't recommend treating these patients unless, of course, they have, you know, someone is planning to get pregnant, has fertility issues, or people who have strong family history and a few other things. But for the most part, mild elevation of TSH does not necessarily. The average dose of thyroxine is 1.6 microgram per kilogram. And, you know, if you have an elderly patient, you start them with a smaller dose. And the reason is that there's a high risk of inducing cardiac disease or heart failure. So you start very slowly and build up the dose. And that is a very common problem that we sometimes see in our. Overactive thyroid is the opposite. We're looking at increased thyroid hormone levels, both T4 and T3, and instead of an elevated TSH, here you have a suppressed TSH due to feedback. However, if you have a pituitary TSH producing tumor, which is super stimulating your thyroid gland, then you can have a TSH which is either high or not suppressed. And I've seen a few patients, but this is very rare problem. The signs and symptoms of overactive thyroid are the exact opposite. These people generally tend to have eye problems, and I'm going to show those to you in a minute. They have anxiety, rapid pulse rate, diarrhea, tremor. They have a bone loss. They have warm skin. So you're obviously very well aware of all these symptoms of thyroidism. Again, the commonest cause in our parts of the world is autoimmune or Graves' disease. You can have toxic nodule or Plummer's disease. You can have multinodular thyroid. It can also happen due to iodine load. Remember, if you take certain big dose of iodine, it will shut down your thyroid. But if you take iodine slowly, then it can over time increase your thyroid hormone production, because iodine is a fuel for production of thyroid hormone. It can also be self-induced. A lot of people use it if they can find to induce loss. In terms of the appropriate history, you ask about symptoms of neck swelling, symptoms of pain in the thyroid, because that will tell you if there is any inflammation, difficulty swallowing. Drugs like weight loss pills, thyroxine, amiodarone can, although in most cases causes hypothyroidism, it can cause thyrotoxicosis as well due to inflammation of the thyroid. Iodine load, pregnancy can lead to thyroiditis. Radiation can lead to inflammation of the thyroid. Remember, thyroid is not just a production facility, but also a storage facility as well. And if anything causes inflammation of the thyroid, your thyroid is going to release more thyroid hormone than rather than just storing it. And if your family history of autoimmune problem, you could have Graves' disease. In terms of other pertinent findings, you have to look for signs in Graves' disease. Particularly, there's lid lag and stare. So these people have very specific stare. They have a swelling around the eye, conjunctival congestion. They have redness of the eye. I'm going to actually show a video in my next slide here, which I'm going to run, and this video will show you a patient of mine. I want you to look at this patient. I asked you to look down, and you can see his eyes are coming down, and then the lid is taking some time. So this is a very classical lid lag, and the lids are retracted back. So this is someone who had Graves' disease and quite a lot of swelling around the eyes. I want you to look at this pen.
I think I do apologize. I think this is just, we'll just move on.
Thank you, sir.
These patients can also have what we call as pretibial myxedema, which is a very classical induration of the skin extensor surfaces, and these people have separation of nail beds, a condition called onycholysis, and this is what we see in patients with. Now, how do you tell different types of thyroid problem? I told you it could be due to nodular disease. It can be due to various due to Graves' disease, and so on and so forth. Well, the classical way to tell is obviously you do autoimmune testing, autoimmune screen. If we look at TSH receptor antibody, and if that is positive, that will tell me it is Graves' disease. And you can do thyroid uptake and scan. In most cases, in our center, we use technetium for the most part, or maybe I-131. Obviously, it varies. And we do a 6-hour uptake. Some centers like to do 20 hours as well. But that is something you guys are way better than me, so I'm not going to go in details. What are the long-term effects of overactive thyroid if left untreated? Well, it can cause a lot of problems. It can lead to osteoporosis, cardiac failure, dysfunction, atrial fibrillation, anxiety. So, I mean, you can end up with uncontrolled thyrotoxicosis or thyrotoxic storm. So these people definitely need treatment, symptomatic. And the treatment for Graves' disease, for instance, in this case, we would typically start, or for that matter, any thyroid problem, we would typically start with beta blockers that reduces a sympathetic tone and normalizes your heart rate. And then, depending upon the type of the problem, we would either start them with anti-thyroid drug. In this case, we have methimazole, propylthiouracil. That's what we typically use here. There are different drugs like carbimazole in certain other countries, but that's pretty much what we generally start. These drugs have side effects. They can cause a rash, they can cause agranulocytosis, and they can cause liver toxicity. Now, these are uncommon, but they can be quite significant problems. So we monitor these patients as we start the treatment. We generally like to give this, in case of Graves' disease, for instance, we like to give them medical treatment for at least 6, likely 12 months. And after that, we stop it. In about 30% of the cases, after stopping the treatment, they just remain in remission forever. They never have a problem. However, if in most cases the problem comes back, and in that case, either we decide if we have a discussion with the patient, either they go for lifelong thyroid replacement, anti-thyroid medication, or you give them radioactive iodine therapy, which you're very well aware of. And in rare cases, you can recommend surgery, which we don't do in the most part. I would also like to quickly talk about postpartum thyroiditis. This is a condition which happens after pregnancy. And this is an immune response. Your thyroid becomes inflamed and it basically just spews out whatever thyroid hormones you have and stored in. So you have this phase of overactive thyroid or thyrotoxicosis, which then eventually, as it runs out of the stored hormone, it goes into a state of hypothyroidism, and then eventually kind of normalizes as the inflammation works its way out. So it takes several weeks and sometimes months. And in this case, you don't need iodine treatment. You basically diagnose cases when you do a thyroid uptake and scan. These people have negative antibodies, they have history of pregnancy, they're painful thyroid in many cases. And if you do a thyroid uptake and scan, it's a negative scan, and I'm sure you all know that, so I'm not going to bother you with details. The scan is generally negative in these cases. And these people can sometimes go and develop permanent hypothyroidism. Toxic multinodular goiter, more common in older patients, particularly older women. This is rare, this type, but in this type of picture, but mostly these you see slightly enlarged. And in this case, you could either give them beta blockers with anti-thyroid drug. In this case, it does not get better. It's not spontaneous, it does not resolve. And in most cases, either you have to treat them lifelong with anti-thyroid drugs, plus you can give them iodine therapy, and that's the permanent solution. I do want to point out something which is geriatric hyperthyroidism. Up to a third of the patients who have older patients, elderly patients who have hyperthyroidism, they actually don't have the classical symptoms of hyperthyroidism, other than they kind of feel anorexic, they have weight loss. Most of them present with cardiac symptoms, and they have atrial fibrillation, or heart failure. So in the elderly, you have to be very careful, and your index of suspicion should be high. And always make sure if somebody's not doing well, you should measure their thyroid hormone level. So in most cases, hyperthyroidism, if you have low suspicion, just measure TSH. That's a single good test. If you have a high suspicion, you measure both TSH and T4, and that can tell if it's primary or pituitary related. If TSH is suppressed and T4 is normal, then you should check free T3, because sometimes these patients just have T3 toxicosis. A Graves' disease multinodal patient, they don't necessarily have high T4, but they just have high T3. So you have to check that. And then you can do your thyroid uptake and scan to confirm the diagnosis. This was kind of a brief overview of how we approach patients with thyroid problem. My 30-minute.
So I'll just stop